Hi, my name is Ajay Chari. I'm a professor of medicine at the Icahn School of Medicine at Mount Sinai, New York. And today I'm privileged to have joining us one of our most seasoned NPs, Daniel Verena. And together we're going to be covering daratumumab, the intravenous and subcutaneous formulations, and what's kind of new and exciting. So Daniel, welcome. Thanks for joining me.
Oh, thank you. It's my pleasure.
So let's get things started. I think just to set the stage, obviously we know daratumumab is a CD38 monoclonal antibody. It's approved for myeloma in several different indications and combinations. In the newly diagnosed setting, for transplant-eligible patients, it's actually approved in combination with VTD or bortezomib thalidomide and dex, so dara-VTD. For the transplant-ineligible population, it's also been approved in combination with lenalidomide and dex as part of the MAIA study, and also with VMP as part of the Alcyon study. So all of these have shown that the addition of DARA has led to significant improvements in not only response rate, but progression-free survival. I think one of the other interesting things about this frontline setting is there's always this question of if you use your drugs early, what might happen? And I think an important additional statement to that point is the Alcyon data from ASH 2019 was updated to show that the addition of DARA not only improved response in PFS, but also overall survival. So I think this concern about using drugs early and potentially getting more aggressive relapse has not been borne out, particularly for the transplant-ineligible population where you don't always get a chance to salvage these patients. And then briefly, in the relapse setting, DARA is also approved in combination with lenalidomide and dex and bortezomib and dex as part of the POLLUX and CASTOR studies, and this is with at least one line of prior therapy. And then it's approved in combination with pomalidomide and dex for at least 2 prior lines of therapy, including a PI and an IMiD or proteasome inhibitor and an IMiD. And finally, it's approved as monotherapy for patients who've had at least 3 lines of therapy, which PI or IMiD included. So those are the current uses of daratumumab and a lot of other exciting studies. And so I think I'll now throw this to Danny. So Danny, you agree, a lot of options to use DARA, and, yeah. And maybe you could walk us through what it's like to give DARA currently, which is in the intravenous formulation.
Absolutely. Thank you. Yes. And I think it's a great option for many of our patients starting even in newly diagnosed, and like Dr. Chari had said, even salvage them in the relapse setting. Because it is a monoclonal antibody, I think many of our patients are concerned about different testing and different side effects that they're going to see. And when we speak to our patients up front, we really talk to them about doing normal labs. So you're going to get your complete blood check, your CBC, your CMPs. You're going to look for, interesting enough that they did find in later data that there was a reactivation of hepatitis B. So now we're testing all patients for hepatitis panel and hepatitis C up front before starting daratumumab if they need any type of medical interventions prior to starting the medication itself. Also, interesting enough, and we may talk about a little bit later, is that because daratumumab is a monoclonal antibody, it does adhere to the CD38 receptor that's located on erythrocytes, and it can interfere with some type and screening of blood. So most patients should have a type and screen drawn prior to their first dose so that your blood banks can know that as it to be in their control, and if they have antibodies in the past. Interesting also is because it is an immunoglobulin IgG kappa, it can cause interference with immunofixation electrophoresis. And why that becomes important down the line is when you're really trying to say if a patient truly is in complete remission or they're in very good partial remission, VGPR, knowing this up front is important. So patients who are IgA or IgM, it really has no bearing on it, but you're really your IgG kappa. So there are 2 tests available. There's a DARA interference assay that is available, and also mass spec. So on a local level, so if the IFE is there and we want to find out whether it is interference from the drug itself, or does the patient still have a very fine amount of disease, that's also important.